30 years ago, the primary complaints in a standard gynecology clinic were structural. Patients presented with heavy menstrual bleeding or uterine fibroids. Conditions like polycystic ovaries were considered rare, often relegated to a brief footnote in medical textbooks. This data visualization shows a stark clinical inversion. Historical structural issues have been eclipsed by systemic endocrine disruptions, metabolic weight gain, endometriosis, and unexplained infertility. Globally, 1 in every 3 to 5 women now suffers from this reproductive dysfunction. We see the immediate consequence of this shift in urban centers, where the rapid proliferation of in vitro fertilization, or IVF clinics, directly tracks with the rising inability of women to conceive spontaneously. Human genetics do not rewrite themselves in a single generation. A global, synchronized failure of the female reproductive system on this scale proves we are looking at an environmentally driven metabolic epidemic. The standard clinical definition of polycystic ovary syndrome, or PCOS, traditionally focuses right here, on the localized presence of cysts on the ovaries. But the name polycystic ovary syndrome is a clinical misnomer. By naming the disease after the ovary, we have misdirected how doctors and patients approach treatment. Biologically, these follicles are not actually cysts. They are a cohort of normal ovarian follicles that initiated development but became trapped and stunted before they could mature. When we treat the ovary directly by prescribing oral contraceptives to force a synthetic bleed, we are merely applying a chemical bandage. The pill masks the physical symptom without touching the underlying pathology. Those stalled ovarian follicles represent the final downstream endpoint of a massive systemic metabolic and neuroendocrine disruption. To restore spontaneous fertility and reverse the condition, we have to abandon the pelvis entirely. The clinical investigation must move upstream, first to the brain, then the pancreas, and finally the gut. This diagram shows the hypothalamic pituitary ovarian axis, or HPO axis. It is the neuroendocrine communication loop where the brain sends chemical instructions down to the reproductive system to regulate the menstrual cycle. In a healthy state, the brain sends a single, clean signal pulse. This triggers normal folliculogenesis, the process where one dominant follicle matures, breaks the surface of the ovary, and successfully releases an ovum. Under metabolic stress, that communication loop fragments. Instead of a clear instruction, chaotic static hits the ovary. Multiple tiny follicles attempt to swell simultaneously, but none receive the threshold signal required to actually ovulate. They simply stall. Because these follicles are partially developed, they are biologically active. They continuously secrete a low, steady drip of estrogen directly into the bloodstream. A healthy menstrual cycle requires a sharp, decisive spike in estrogen, followed by ovulation and a subsequent drop in progesterone to trigger a natural period. The stalled follicles create a chronic hormonal flatline, preventing this withdrawal bleed entirely. Chronic anovulation signifies a highly sensitive communication loop awaiting the correct systemic instructions. If the brain is sending static, we must look at the systemic bloodstream to find the interference. The primary disruptor of the HPO axis is cellular insulin resistance. When the body becomes resistant to insulin, the pancreas pumps out massive quantities to compensate. This hyperinsulinemia forces heavy insulin molecules to aggressively bind to ovarian receptors, which chemically commands the ovaries to overproduce androgens, or male sex hormones. Once those localized androgens hit the bloodstream, they travel to secondary sites. This internal spike maps directly to the external visible phenotypes of PCOS, hirsutism, or excess facial hair, deep jawline cystic acne, and male pattern scalp alopecia. The standard medical reflex is to prescribe metformin, a drug that artificially forces blood sugar down, but this ignores the biological reality of why the cells are resisting insulin in the first place. The high testosterone, the abnormal hair growth, and the stalled ovarian follicles are simply the downstream collateral damage of a pancreas working in extreme overdrive. To find the origin of that systemic insulin resistance, we have to trace the pathology to its root cause, the gastrointestinal tract and the microbiome. The gut lining is designed to function as a highly selective biological shield. It absorbs nutrients while keeping dangerous pathogens out. But when that biological shield fails, the epithelial cells physically pull apart. We immediately see a dangerous, rapid increase in intestinal permeability. The modern environmental diet, specifically ultra-processed foods, high fats, and dense carbohydrates, chemically degrades the tight junctions holding these epithelial cells together. The immediate biological consequence is structural failure. Their unnatural presence triggers a massive systemic inflammatory response. Waves of inflammatory markers coat the body's cellular insulin receptors, physically blocking insulin from doing its job. This is compounded by excess branched-chain amino acids, or BCAAs, found in heavily processed proteins. These BCAAs activate the mTOR pathway, a cellular signaling mechanism that regulates metabolism, which further deepens the cellular block against insulin. The sequence is clear. A highly processed diet dissolves the gut's biological shield. Leaking bacteria chemically blind the body's insulin receptors. The pancreas overcompensates, and the resulting hormone storm suffocates ovarian function. Diet is not the only trigger. The gut barrier and the HPO axis are highly sensitive to psychological stress and disruptions in sleep architecture. Clinical data isolates a specific critical threshold for circadian damage, the window between 10 p.m. and 4 a.m. The margin for error is incredibly thin. A sleep deficit of just 2 hours within that specific window, for only 25 days out of the year, classifies a patient as having the severe metabolic risk profile of a shift worker. This circadian deficit yields a precise chemical result: high levels of the stress hormone cortisol and heavily depleted melatonin. Together, they act directly on the brain to suppress the HPO axis and halt ovulation. Modern late-night productivity and screen habits are clinically indistinguishable from severe metabolic trauma to the female reproductive system. There is a massive clinical blind spot in gynecology, the assumption that PCOS and insulin resistance only manifest in patients who are clinically obese. This brings us to the lean PCOS presentation and the concept of TOFI. TOFI stands for thin outside, fat inside, a condition where a person appears healthy on the scale but carries dangerous, inflamed visceral fat wrapped around their internal organs. Physically thin patients suffering from PCOS frequently exhibit severely altered fat-to-muscle ratios. They are often experiencing premature sarcopenia, which is the accelerated, unnatural loss of skeletal muscle mass. Skeletal muscle is not just for movement. It is the body's primary metabolic sink for glucose disposal. When muscle tissue shrinks, glucose is rejected, diverting back into the bloodstream to trigger massive insulin spikes. Because estrogen protects the bones and the heart, this lack of muscle mass, combined with anovulation, accelerates severe menopausal complications decades early, leaving thin women highly vulnerable to osteoporosis and cardiovascular disease. Thinness is a terrible proxy for metabolic health. Lacking skeletal muscle is a guaranteed pathway to systemic endocrine failure, regardless of the number on the scale. Transitioning to spontaneous ovulation requires specific, data-backed clinical interventions to reverse this systemic cascade. First, the dietary requirement. Patients must restrict carbohydrate intake to under 100 to 150 grams daily. Simultaneously, eliminating ultra-processed foods is mandatory to starve out the pathogenic gut bacteria and allow the intestinal barrier to reseal. Next, the non-negotiable lifestyle interventions. Strict adherence to the 10 p.m. to 4 a.m. circadian sleep window and aggressive skeletal muscle accretion through heavy strength training. This flowchart shows how these specific interventions work together in sequence to reverse the pathology. Restoring gut integrity lowers systemic inflammation. That restores cellular insulin sensitivity, which finally balances the HPO axis and allows the ovary to spontaneously ovulate. Time is the absolute critical variable. This massive metabolic override rapidly depletes a woman's finite ovarian reserve. Clinicians measure this decline through AMH, or anti-Müllerian hormone, a blood marker indicating remaining egg supply. Leaving insulin resistance untreated accelerates premature ovarian aging. Female reproductive health can no longer be siloed into localized gynecology. A functioning ovary is a biological marker of a woman's total systemic metabolic integrity.